Okay, we're gonna go ahead and get started. Thank you all for coming and braving the cold. I know it's freezing out there. We're just gonna start. We're gonna have a couple more announcements than we usually do, just because I know some people who are here tonight haven't been here in the past. So we're just gonna go over like a few logistical things, and then if you have any questions, you can come up to me and ask. That door. Thank you. So this is just your executive board for this year. Like I said, most of you have already met us and stuff. But if you ever need to contact us, you can shoot us an email or a text. We're always here to help. This is our spring schedule. All of our GB meetings are going to be in this room, like always, except for the February 12th meeting is going to be in the Interfaith and Prayer room that's also in the Union. I don't know exactly where it is, but it's somewhere here. Is it upstairs? Okay, cool. Yeah, this way, right? It's somewhere upstairs, but we will send out something about it before the meeting. And then you'll notice that a couple of our executive board meetings for this semester are closed. That just means that GB members are not allowed to attend just because we're going to be talking about elections and stuff like that. So we're not allowed to have GB meetings or GB members in the EB meetings. So membership status, this is also just a good reminder for people who have been here and just don't quite remember. There's 2 levels. There's good standing, which means you pay dues and you attend 4 GB meetings, or you can be in active status, which means you pay dues, attend 4 GB meetings, and also earn 3 additional points. So that can be through socials, going to a fundraiser, going to a volunteering event, joining a herd group, which we're going to talk about in a sec, or anything else extra like rounds or anything that we do. Does anyone have any questions on that? So dues for the semester are $11. If you already paid last semester for the whole year, we have you marked down. But if you haven't paid for this semester, if you're new, or if you just paid for last semester and haven't paid this semester, dues are due by Wednesday, February 12th. So that's a GB meeting. And you can Venmo Emily. Make sure you include your first name, last name, number, and your phone number. Because if you haven't been here yet this year, we do have a new group me for due paying members only. And the only way we can get you into the group me if you're not already in it is through putting your phone number into the Venmo. So make sure you do that. We can send out her Venmo in the chat as well. This is a census that we have that we usually give out every year. We just kind of want to know like who's in PVMA. I think we had this last semester, right? So I don't know if you need to fill it out a second time. But yeah, if you want to scan that, we'll send all these things to the group me as well. Since I know I'm kind of flying through it, but if you haven't, you can go ahead and scan that one. Okay, this is something exciting that we're bringing back this semester. We used to do this a couple years ago, I think. But basically it's called herds, and it's just kind of like a small group thing within PVMA. So it's kind of a great way to meet people in the club and also to interact more with your executive board members. So it'll be like, you'll get divided into groups, and then each group will have like 1 to 2 EB members. And you guys will just go on little hangouts, like go to sporting events, go to coffee date, whatever. And we are saying that each herd has to plan at least one thing a month, aka the EB will plan it, and you guys will vote on it and stuff like that. But you will get a point for attending herd events. So if you're in need of extra points for elections, which I'm also going to talk about in a couple seconds, this is a great way. So if you guys want to scan that, if you're interested, go for it, or else we will send it to the chat as well. Okay, elections. So I'm not going to go super into depth about this yet. We'll talk more about it in February. But election requirements, because I know it's coming close, so a lot of you guys probably want to start thinking about what you have in terms of membership stuff. So you have to be an active member for at least 2 semesters, aka last semester and this semester, or last semester and the semester before. And basically, like I said before, to be an active member, you have to attend 4 GB meetings, pay dues, and get 3 additional points. You also have to attend 2 executive board meetings, and these do not count as additional points. The only things that count as additional are like socials and stuff like that. And then nominees for president, vice president, program coordinator must have been an EB for at least a year prior. Nominees for treasurer must have been an active member for 3 semesters before rather than 2. Elections are going to take place on March 19th. It is a GB meeting. It's just the regular time. It's going to be in here, 7 to 8. I will say usually it does go longer because we have people speaking and stuff. So if you do plan on attending, just know it probably will go long. And we do like GB members who are not running for elections are still begged to come because that's who's voting. We're not voting. The GB members are voting on who you want as your EV members. So even if you're not planning on running for a position, please still come so you can vote and we can get a great EV for next year. And like I said, I'm going to talk about this more in depth in a couple meetings. I'm going to have like a little spiel after the meeting so you guys can stay, listen to that, and then ask questions if you need it. But just know these are the requirements, so be keeping it in mind as the semester is progressing. Hello. Okay. Upcoming events, we have our first fundraiser coming up on January 22nd from Open and Close at BB It's the one on North High Street. And then other events, Emily sent in the chat, we did just donate $800 to Columbus Humane this weekend using money made last semester through dues and merch and fundraisers. So thank you all for anyone who paid or went to a fundraiser or anything because I'm sure they really appreciated it. CFACE SAMA reminders, first CFACE council meeting is on January 22nd from 5 to 6. And then SABMA upcoming GB meetings they're usually on Mondays, I think once a month, February, March, and April. And we'll send stuff in the email and in the group chat about this. So. Does anyone have any questions about anything that I just spit at you? Cool. All right. I will hand it over to Dr. Cooper then. Thank you.
All right. Well, thanks for inviting me here this evening. My name is Ed Cooper. I'm one of the faculty in small animal emergency medicine and critical care at the vet school. And so the Pre-Vet Club team asked if I could come and talk about kind of life in emergency medicine, as it sounds like there's a fair bit of interest in EMED and kind of what are the career options, and obviously you're a ways from that path, but ultimately whatever measure of interest that we can foster in emergency medicine and kind of what distinguishes an emergency vet from an ECC specialist and things along those lines. And so part of it as well, and that will sort of extend a little bit of the introduction and provide some background on myself. I was asked to kind of present my journey as it has happened and gotten me to this stage. And I'm sure Montana was very quickly able to recognize when the old person came in that was probably Dr. Cooper here to talk about a life in emergency. So the sort of joke title of this is Sunshine and Rainbows, a life in emergency medicine, because it's not really sunshine and rainbows. We do see puppies and kittens, but not in the cute and fluffy way that we would always prefer. I think of emergency medicine as more like toxins and trauma and chaos, oh my. And some of the aspects of the very interesting and exciting and sometimes tragic nature of the cases that we deal with, because emergency and critical care medicine is going to be the sickest of the patients, the ones that require the highest level of care, as well as you get the biggest wins and sometimes the saddest losses. And so that is just a function of emergency and critical care. And I think that's true of specialty medicine in general, but particularly compared to, let's say, primary care or general practice, we're going to experience a lot broader spectrum of highs and lows than in general veterinary medicine. And so as far as outline for this discussion, again, I'm going to talk to you a little bit about how I ended up where I am today and some of the steps and missteps that I managed to take along the way, as well as what are the opportunities related to emergency and critical care medicine, and then a few of my favorite cases to hopefully offer a little bit of insight of some of the really cool things that we can see in the ER. So My journey started in Northeast Philadelphia, where I was born and raised. Anybody from Philadelphia or? Okay, one, great, solid. Represent. So, I sort of grew up always with an interest in math and science, as you could probably get the nerdy vibe. And my initial plan was that I was going to become a physician, like a human doctor. My mom was a registered nurse, now retired, but came home with enough stories from the human medical profession that my vision of human medicine was sort of felt like that. And so kind of combining, I like science, I like medicine, love animals. How about veterinary medicine, which is probably common for a lot of people in this room, putting together those pieces of, is that the career that I want to seek for myself? So about 10th grade, solidly, I'm like, yep, I'm going to go to vet school. And I lived in Philadelphia, and they took some pity on me. And so I got accepted to undergrad at the University of Pennsylvania, which is pretty sweet. It turns out they also have a vet school, so that would work out well with my career goals. And then I got to about the start of my junior year, and I was like, I should probably like start to look at the application for veterinary school and what that's going to entail. And I saw questions like, describe your experiences in veterinary medicine. What different roles do veterinarians play? How many hours have you worked in the veterinary setting? And you need to provide at least one letter of reference from a veterinarian. Um, and so as a very, I guess, naive and deluded individual, I had never worked in a veterinary clinic at this stage, junior year of college. I had never gotten more information about the profession. Like we had our family veterinarian and we took our pets there and I was like, yeah, that seems cool. I want to do that. I never actually like shadowed or spent time. I was just like, I'm going to be a veterinarian. I'm sure it'll work out okay. And I never got exposure to any other animals aside. And I grew up sort of in like Philly, like not on the outskirts. Like, so among the all creatures great and small, this was the census which I had had exposure to, and it was entirely the own pets that we had in our household. So imagine, and depending on where you are in your undergraduate status, starting my junior year of college, nothing. I had done nothing to prepare myself for this like very linear path that I had chosen, that I'm going to be a veterinarian. Not very smart. Not very smart. So a little bit of panic sets in. The applications were due in like, I don't know, 5 months or something along those lines, because this is August-ish of my heading into my junior year of college. And so what am I going to do? And then a light dawns on me after 2 years on campus at Penn. Hey, there's a vet school right down the street. Hadn't really occurred to me to maybe like wander over there, talk to some people, seek some opportunities. There's a vet school like right over there too, just if anybody was wondering. Um, and so I finally stop in as I'm panicking and say, hey, what opportunities exist for people interested in getting some exposure to vet med? Because I really want to apply to vet school. And they were like, what year are you? Junior. And they were like, oh, okay, you're in trouble. So they did mention that they accept undergraduate volunteers to kind of help out in the ER at Penn. And so I reluctantly signed up, not really knowing what I'm going to be getting into. And I had seen medical dramas and I had this sort of vision of what the ER might look like, but really didn't have any practical sense of it. And so I was like, okay, we'll check this out. Hopefully I can get a letter of recommendation from somebody. Like I don't make anybody mad. Hide in the corner and try to get a letter. So then my very first volunteer shift in the ER at Penn, I'm kind of huddled off into the corner. They had given me a little bit of orientation, but they were like, you'll figure it out. And I'm like, cool, because I've really not even really been in a true veterinary hospital setting in the treatment area. And so 15 minutes in, this is a true story, they call a stat triage for an HBC, which I learned was a hit by car, in case you're wondering. And it comes in over the intercom, and the whole team kind of mobilizes. I did not mobilize. I stayed in my corner. And the team goes out to the waiting area, and they roll back with this dog on a gurney that had just been hit by a car. And the next hour or so experience basically then served to shape where I am today. So if you're wondering, where's it going? This is where I'm going. And what I witnessed as this dog rolled back, the nursing team, the assistant team, the clinician, the doctor team just created this cyclone of orchestrated, beautiful, controlled chaos. Like so many things were happening at the same time. So many aspects of the patient were being assessed and addressed. And it all just happened in the blink of an eye. And the amount of kind of coordination that was happening among all these different people, a lot of it without saying a whole lot. Like everyone just knew what to do. And I was like, this is so cool. And like, again, I had watched medical dramas and I had seen that sort of thing happen on TV, but to see it happen in real life in front of me was awe-inspiring. And at the center of the orchestrated chaos, the conductor, if you will, was this guy named Ken Drobats. And he was a boarded criticalist. He was the head of emergency and critical care for Penn at the time. And he was this guy from California who was just like, dude, like he was just so laid back and all this chaos is erupting. And he's like, okay, yeah, we're just going to do this. And hey, do you want to grab that over there? And can somebody run this blood work? And it was just like beautiful. And so that forged my passion for emergency medicine. And that day I decided that not only did I want to become a veterinarian, but I wanted to specialize in emergency. And I didn't know a whole lot about it yet, but I was like, this is cool. This is what I want to do. Now, it may have been a bit narrow-sighted to, this is my first real exposure to vet med. And I'm like, yep, that's what I'm going to do. But remember, I was also the guy who in 10th grade was like, yep, I'm going to be a vet, and then did nothing to actually make sure that that is what I wanted to do. And I wanted to work in a teaching hospital because seeing the role of all the different players in this orchestra, the technicians, the interns, the residents, the faculty, like it was just so cool. And they're saving lives and teaching all at the same time. And I was like, gosh, I want to be a part of that. And then I was like, and it would be really, really cool to be that guy, Ken Drobats, and be the head of an emergency and critical care service. So I wanted to be that guy. And so in the beginning of my junior year of college, I decided I stacked onto, I want to be a veterinarian, but I want to be an emergency vet. I want to work at a academic hospital, and I want to be kind of the guy in charge someday. But I probably should take some steps prior to that. And so I continued my position as a volunteer, which then was able to kind of progress to being an assistant, and then ultimately, and the laws in Pennsylvania are a little different than they are in Ohio. You can technically be a technician, you can be a nurse without certification, without going to school and things like that. And so one day I got deemed a technician, a veterinary nurse, still working in the ER through the course of college. I managed to get that letter of recommendation, which proved to be pretty helpful, and got accepted into vet school. And I continued to work in the ER as a technician through the course of vet school, basically evenings, weekends, over the summers, again, very myopic, very focused, and kind of focusing in on that career in emergency medicine. And so graduated from Penn with a VMD. Is that anybody know what the VMD stands for? Like Penn's the only one that confers a VMD. Yep. Yeah, absolutely. So every other vet school confers a DVM, Doctor of Veterinary Medicine. Makes good sense. Penn was initially an extension of the medical school, so it was like, oh, we've got MDs, Medicinae Doctoris, so we're just going to be Veterinare Medicinae Doctoris. But really what it stands for is very mediocre doctor, VMD. So if you ever come across the Penwe and they're like, "Ooh, look at my VMD," just know that it stands for very mediocre doctor. So part of the process, if you want to be a specialist, and we'll talk about this a little bit more, is after vet school to do an internship, a rotating internship. And so there's this whole matching system where basically you apply to a bunch of different internship programs, and then you rank the programs that you want to go to, and they rank the applicants that they want to take. And then some computer goes, bleh, and one day you discover you're going to East Lansing, Michigan, for example. So I matched at Michigan State University for my internship. So I made the journey for the first time, grew up in Philly, went to college at Penn, went to vet school at Penn, left the Philadelphia area for the first time really in my life in any appreciable way to head off to my internship at Michigan State. And that was a great year. Rotating internships are kind of classify as both the one of the more grueling and we'll say character building experiences that you can go through, and at the same time helps to really forge you as a doctor, as a clinician in those initial stages after graduation. And so loved my time at Michigan State. And so went on to apply for residency in ECC, and that's a 3-year program, and that's when I landed at Ohio State. So I came to OSU for my residency. They had actually just started their residency program at OSU's vet school, and so I was technically the first resident that went through the program. And after a year, like I loved my internship. I loved all the people I worked with. I don't know if anybody here has ever been to East Lansing. Um, there's not like a lot. It's a college town. It's a very fun place to be. But I was like, okay, I'm going to expand my horizons and head to Columbus, Ohio, which I had also never really been to before. And so was pleasantly surprised at all that Columbus has to offer. And so much so that after I completed my residency and a combined master's program and passed the little quiz that they make you take to become board certified, I decided to stay at Ohio State as faculty. So I've been here as faculty since 2007, which, as I do some quick math, is like 17 years. And I became the section head for emergency and critical care in 2010, and I've been in that position since then. So up to this point, including internship, residency, and my time as faculty, I've had over 3,000 students, over 300 residents from all the assorted specialties that I've kind of had contact and exposure to train, and almost 200 interns. So lots of teaching opportunities, lots of people wonderful people that I've gotten to work with, still counting. And I'm also, along the way, managed to find time to get married. And actually, my wife was one of the technicians at Michigan State when I did my internship, and I stole her from them and brought her to Ohio State. So that's me and the two-legged children, and of course, we've got a few four-legged children. Colin's the older son on the left. Cameron is the younger son on the right. They are actually now 14 and 16 years old. They feel as though any pictures or attempted pictures of them steal their soul or something. They won't allow it. This is one of the most recent pictures that I have, and it's probably 5 years old. So they're older and meaner than they used to be. And then in the middle there is Fletcher is a pity mix. It was a rescue from the Delaware County shelter. And then next to him is Eleanor, who is a French bulldog that presented to the veterinary medical center because she has really bad pulmonic stenosis. So her heart doesn't work well. And the breeder was going to give her up, and we wound up adopting her. And so she's about the third of a size that a French bulldog should be, but she's 3 times the personality, and absolutely rules the pity. He is her favorite pillow, as you can see in this picture. And then the kitties there, on the top is Peg, so named because she came to us as a Good Sam stray cat, that had basically no foot. It's called carpillagenesis. And so it just never grew, and it was infected in an open wound. So we adopted her and very cleverly called her Peg for peg leg, because she's got no foot. And then down below her is Gertrude, and she has cerebellar hypoplasia. So that is when a part of your brain that controls balance doesn't work very well. And so she kind of does this, but lives a perfectly happy existence, and is somewhat amusing to watch as she tries to get around. And that's one of the things about being in the veterinary profession is quite commonly you're going to end up acquiring an assortment of pets, which can be a very nice and fulfilling thing, but also like have to have limitations to the number of pets that you choose to take on. And so that's why my wife and I established a firm 2, 2, and 2 rule. 2 children, 2 dogs, 2 cats. That's it. And every time that someone's like, Cooper, don't you want this dog? I got the 2, 2, and 2 rule. Can't do it. It gives me an out to feel less bad when I can't accept every stray pet that happens to come along. So that's a little bit of my journey and how I got here. My job at Ohio State is, aside from my family, the most fulfilling thing that I could have hoped for. And the dream of kind of getting to this point ended up happening, but I was not very clever about it. And so for anybody here that is obviously considering vet school, make sure that you're getting those experiences in. Yes, this is what I want to do with my life. And out of curiosity, is anybody in here one of our ICU pet sitters? Okay, so a few. That is, for those that don't know, there is an opportunity to come to the Veterinary Medical Center and spend some time in the ICU. You kind of hang out with some of the patients in ICU, offering them some comfort and support. And it's an opportunity to just get a little bit of exposure. And while you're doing that, you also get to see all the sort of cool chaos that's happening around. We don't have a lot of opportunities for like people that just come and hang out. They're like, even the pet sitters have to sign this like, yes, I'm coming in there, and waiver sort of deal. And so if you email me and say, hey, can I just come and hang out? Unfortunately, we don't have good opportunities for that. The pet sitter program is the best way to come spend some time in the emergency critical care service. Okay. All right, so let's talk a little bit about some of the opportunities in emergency and critical care, sort of as a career, as a kind of contribution to veterinary medicine. And I want to touch on sort of those opportunities as they exist in general practice. Relatively new to veterinary medicine is urgent care, as well as being an emergency clinician versus being an ECC specialist. So in the primary care or general practice setting, there is lots of opportunity to be exposed to emergency cases. So theoretically, anything can walk in the door, and each practice tends to decide how much or how little emergency type stuff they're going to do, see, allow, things along those lines. And some clinics will also have sort of after hours on call. So the client calls in and says, my dog's not doing well. It's 10 o'clock at night. Yep, I'll meet you at the clinic sort of deal. I think overall, there's less of that than there used to be. I think as there's more emergency urgent care dedicated facilities, there's probably less of that, which is probably good for the work-life balance of people in primary care settings. And in the general practice, again, if they choose to see emergent cases, there's opportunity to participate in some of the cool emergency surgeries that, removing intestinal foreign bodies, they're bleeding into their abdomen because of a ruptured tumor, things along those lines, that can be done in the primary care setting. The limits to doing emergency medicine in primary care is that you're also seeing appointments. And so you're not just there to handle emergencies. And so you're having to interweave the cases that you're already scheduled to see in 15, 20-minute appointments and an emergency that comes in the door. And that can be really hard to do. And again, that's where each practice decides, are we going to take walk-ins? Are we going to see emergencies? How many are we going to take? And how are we going to adjust things if that happens? So again, that can be a little bit of a moving target. A lot of the primary care settings, because they might not see emergencies on a consistent basis, it's maybe not worth having all the equipment and supplies and some of the things that it takes to do emergency medicine. And so that practice may just choose not to have those things. And if those are what are required to care for a really sick emergent patient, then you probably can't do that in that practice setting. And a lot of practices don't necessarily have overnight care, and most emergency situations, or a lot of emergency situations, may require that. Now, you can still see that emergency case, and then kind of do some of the initial stuff and then get them off to a 24-hour care facility, or get them referred to an emergency specialty practice, academic practice that can kind of take the baton and run with it. So, and in some ways that's kind of cool because you can do like some of the initial cool stuff, and then it's like, and then off you go, and somebody else deals with the longer standing stuff. It's also not uncommon that if a practice sends us an emergency case, it needs overnight care, then we may send them back to that practice the next day if they're interested in that, for them to provide the ongoing care. So, and some emergency clinics or after hours clinics actually establish a symbiotic relationship with some of the local vets where they're treated during the day at the primary care clinic. They go to the after hours place overnight, back to primary care the next day, and kind of shuttle back and forth. Obviously, the owners have to be willing to do that, but that's an opportunity as well. So urgent care. Urgent care is relatively new to veterinary medicine. Urgent care has existed on the human side for a long time, right? And so it's like they need sort of a more timely assessment, especially after hours, but maybe they're not so sick that it's clearly indicated to get them to the emergency room. So that's where urgent care falls on the human side, and that's where we're starting to incorporate it on the veterinary side. And OSU, we have an urgent care clinic up in Dublin that's sort of our sister clinic. And through our combined phone system, we kind of use that as a way to, as clients call in, based on keywords and whatever the concern is, oh, head to our emergency facility. Oh, you can go to our urgent care facility. And at the urgent care, it's lower impact stuff, so they can get through things a little bit faster. And if it's like an ear infection or a hot spot or pretty much anything related to the skin, I don't want that in my ER. That's not exciting, but they need help. So that's where urgent care comes in. And some primary care clinics are also providing sort of in the evening urgent care options. MedVet is working on some urgent care options as well, so that there's that middle ground of, I don't need full-on emergency, but I can't wait to see my primary care vet. Let's get you into urgent care. Now, things can walk into an urgent care, and some of the sicker things that end up with us start off at our urgent care facility. And so being an urgent care doctor doesn't mean you don't see anything exciting. You see a little bit less of the exciting stuff, but there's still opportunity to recognize and stabilize really sick patients, and still opportunity to play a role in that care system in the after hours. And it is predominantly in the evenings on the weekend. So most urgent cares are not open during the day, at least so far, because the thought is they're probably going to go to their primary care vet if they can. And if not, they can hang in there until 3, 4, 5 o'clock when the urgent care opens up because it's not so pressing that they need to be seen immediately. And if they do, then they should go to the ER instead. The limitations of urgent care, again, it's only typically weekend and evening hours. And it's some of the less cool cases, but those can be fun too. There may still be limitations in the amount of equipment and resources that are available, especially for some of the sicker cases. Most urgent cares don't hospitalize overnight. So if our Dublin urgent care sees a case that needs hospitalized care, they send it down to us. So again, it's like a feeder system where they can help to triage and sort through, yep, you can be seen on an outpatient basis. Here's some meds, go home, or this may be more significant. Let's get you down to the ER. And then from there, we're going to determine what specialty service they need to go to. Most urgent care facilities don't do surgery except for minor wounds because there's just not time and personnel typically to also try to run an OR. And so urgent care can provide a nice bridge between primary care and emergency care. So from the standpoint of an emergency clinician or an ER doc, they are really going to be focused on receiving emergency cases, either in a dedicated ER practice or a private specialty practice that also does emergency stuff, or in an academic practice like we have here. So training to be an ER doc, technically none. Like you could graduate from vet school and go be an emergency doctor. I don't recommend that because it is becoming a veterinarian after vet school. And like we try in the curriculum to provide as much immersion and exposure. And we talk about this thing called day one readiness. There's truly no day one readiness. There's no way through the course of vet school you could have seen and learned and done everything to account for anything that can come in the door. And so I personally think on the human side, an internship and residency is required to be a physician. Like you can't like, I went to med school, now I'm a physician. Doesn't work that way. You have to do an internship. You have to do a residency. We don't require that in veterinary medicine. Practically, I don't know if we'll ever require that in veterinary medicine, but the opportunity to practice vet med in and of itself is hard to do, and you still need good mentorship in whatever practice that you end up in. But for emergency, when the sick and dying stuff and split-second decisions have to be made, jumping right into that seems a little scary to me. And so my recommendation is that doing a rotating internship, if you're interested in a career in emergency medicine as an ER doc, is the best way to provide the well-rounded exposure as a doctor, right? So as a fourth-year veterinary student, you go through rotations in internal medicine and surgery and cardiology and all those things. But it's different doing that as a student than it is as a doctor. And as an intern, you go through all those rotations still, but as a clinician and seeing it from the clinician perspective and learning it a little bit more directly from the clinician perspective. And so doing that rotating internship provides a little bit more foundation with structured mentoring and support. And there's a lot of private practices that will provide great structured mentoring and support. I'm not discounting that, but if you want to do ER, remember ER is everything, right? So any patient can walk in the door. And so having that exposure is very helpful. Most rotating internships are about a third to even half emergency. So if you're interested in doing an ER career, you're still going to spend the majority of your time doing ER, but you also get time with medicine, time with surgery, time with cardiology, neurology, all of the things that could potentially walk in the door as an emergency clinician. And there are also what are called emergency mentorship programs. So rather than being a year long, these are typically 3 to 6 months, meant to be kind of more ER focused. So you spend pretty much all of your time on emergency. And a lot of the bigger, especially private practices like MedVet and Blue Pearl, have these mentorship programs that are opportunities to come out of vet school with kind of focused ER immersion and training as a clinician that is not as long as doing an internship, but also doesn't provide as broad of an exposure as a rotating internship does. You don't necessarily get time with some of those other specialties. In addition, a lot of the mentorship programs don't necessarily have ECC specialists that are providing sort of guidance and oversight on the emergency medicine that you're doing. Some of the mentorships are that ER doctor has worked here for 20 years, and I'm sure they're very, very good at their job. They're teaching you what they know versus in an internship where you may be under the support of a boarded ECC specialist, hopefully providing the most recent information that we can. And there's currently no certification. There's no test that you have to take to say, I am a certified emergency doctor. There may be in the near future. So that is something that is being sort of put forward as, because again, you could roll out of vet school and be an emergency doctor. Is that the right thing? I think is the question. And shouldn't there be some structured training, some way to say, yep, I'm going to do a good job as an emergency doctor, get a certificate, pass a test, do something to kind of add credibility to the emergency clinician. And then we have the ECC specialist. So emergency and critical care. So the ER clinician is really focused on emergency medicine. The ECC specialist does both emergency and critical care. So emergency is like, please don't die. Great. Critical care is, and let's continue to keep you alive. And so there's a lot of crossover, but also kind of different things and different levels of understanding that are necessary to do critical care compared to emergency. Like critical care is, I'm going to put this patient on a mechanical ventilator and keep it there for 3 days. I'm going to do dialysis on this creature. I'm going to have it in hospital for a week, modulating all of its fluids and electrolytes and doing everything I can to keep that patient alive and to get it better. And depending on the circumstances, ECC specialists do still have opportunity to receive emergency. Because a lot of times people will be like, oh, I love emergency, I'm going to do ECC. And it's important to know that there's that critical care part. And in private practice, most criticalists or ECC specialists do critical care. They have ER doctors that receive emergency and ECC specialists that do the critical care part of it. At our hospital, and this is part of the reason I love working at the VMC, is I get to do both. I split my time between ER because I get really excited, acute cases, yes. And then after like a week or two, it's like, oh, there's more vomiting and diarrhea. Okay, cool. And then I flip over to critical care. And now I'm like, oh yeah, this thing's really sick. I'm going to get to think about this and really come up with a great plan. And then it was like, but I missed the ER. So then the next week I hop back over to the ER. So we kind of get to play both worlds. To be a specialist in general, so you have to do a rotating internship. And for the most part, as it stands right now, the mentorship programs are not sufficient for most residency programs to qualify as the pre-training that we're hoping for a patient that comes into a residency program. And then the residency itself in emergency and critical care, 2/3 of our time is spent in emergency and critical care. And because remember, ECC, we have to deal with pretty much anything. 1/3 of the residency is also still spent with some time on medicine, with some time on surgery, with some time in cardiology, with some time in neurology, maintaining that breadth of exposure, but each level getting to a deeper and deeper level. So you sort of learn one level as a student, now you learn another level as an intern, and now you're learning a different level as a resident to get to that kind of true specialist nature. And then you do have to take a little quiz, a board exam at the end of the 3 years, which personally for me was maybe the most excruciating testing experience that I ever experienced. Um, but you know, built character, and here I am. So it is a lot of work to go to that full extreme of being an ECC specialist, and it is also the best way. And for the most part, in an academic setting, we, if you want to be an ECC practitioner, you probably need to do internship and residency. That said, we also have emergency doctors in our section that again are focused on emergency receiving, but then they also get the, I'm in a teaching environment. I get that kind of gratification of teaching students, helping the interns, things along those lines. So being an emergency clinician doesn't have to be just emergency practice. It can also be in an academic setting. And so kind of looking at, should I become an ER doctor or should I consider being an ECC specialist? The big benefits of being an emergency clinician is you kind of move into practice sooner, higher pay. You get to start getting pay. Interns, residents don't make like a lot of money. But then once so as an emergency doctor, you start generating salary a little bit faster. And you're more opportunity to do emergency surgery if you're interested in that. The biggest drawbacks of an ER clinician versus an ECC specialist, there's less training, less foundation. Like you get good at knowing what you know, and less opportunity to dig deeper. And so that's kind of the biggest thing. And then once you get through the internship and residency, typically an ECC specialist is able to command a higher salary than an emergency clinician. So it takes a little time to get there, but in the long run, if money's a motivator, is then that you do end up making more as a specialist in the long run, which makes sense. All right. So before I start jumping into some quick, interesting cases, any questions about ECC? Yeah.
To be like an ER doctor, like an ER certified ECC or something like that, why would you recommend doing like the rotating with cardiac, neuro, etc., instead of like learning ER and referring those cases to?
Yep, that's a great question. So why rotate through the other, so just so like the recording gets it, why rotate through other services? Why not just learn sort of the management of a cardiac issue from an ER perspective? I think the opportunity is to get a little bit deeper understanding, because as long as it's from the ER side, as long as it's something that came in and you saw it before, you kind of know how to deal with it. If you get a broader foundation, then even though it's not quite the case that you saw that last time, it's now a different case with a little bit of a twist on it, your ability to manage that because you did get some perspective from a board certified cardiologist. You got some of that perspective from a board certified neurologist. So it just deepens the level of understanding is the hope. So that you can not just think about what you saw on an emergency basis and tackle that, but try to see anything that comes in the door. Any other questions? Yeah. Oh yeah, all the time. We call that limited resource medicine. And so one of the key aspects, I think in veterinary medicine in general, but particularly for emergency medicine, is I always go into the room once I've cooked up a plan with a backup plan and a backup plan. And then I kind of decide, if I have two options that are fairly equivalent in nature, like we could keep you overnight for some supportive care, or I could do some fluids under your skin and send you home. I think either one is fair, then I would offer those options. And depending on the owner's level of concern, their finances, they can then decide which one they want to choose. However, if I have a patient that's pretty sick and I'm like, ooh, ideally we should keep this patient, but if we can't keep them, I do have this backup plan. I offer up the first plan. And it's only if they decline that I will then say, okay, that's very understandable. If that's not a possibility, okay, well, we can try this as well. Because if in that second circumstance, I still offer both options at the same time, they're just going to see the cheaper one, the easier one, and they're going to pick that, even if what I'm recommending is the other option. So yeah, so all the time we have to figure out this is ideally what we would do, and here's what we can do, and adjust the plan accordingly. And then obviously one of the practical aspects is if they can't do a whole lot and hospitalized and a high level of care is needed, then unfortunately we're going to have to consider euthanasia. And how is that going to sort of play a role in this? And that is one of the downsides of emergency medicine is we definitely euthanize a lot more stuff because of the acuity, because of the fact that not everyone can afford $6,000 to take their pet to surgery on an emergency basis. And once an owner has indicated that they don't have the finances, then I make it all about, you know, we don't know for sure if going to surgery is going to get them through. And even if we had all the resources, there's no guarantee. So then I try to mitigate the guilt that they feel because they don't have the money. And then I make it about the disease process. Let's blame the disease, not the fact that the money isn't there. Okay. All right. Yeah.
Do you have any regrets in your path or anything you wish you could do differently now?
Regrets in my path. Yeah, the whole I really should have exposed myself to veterinary. I mean, again, it worked out okay, but it would have been a rude awakening if I finally immersed myself in vet med and that wasn't what I wanted to do. So I definitely should have reached out to clinics, gone 3 blocks down the road on campus at Penn and gotten exposure to different aspects of veterinary medicine earlier on. I was driven and focused, but in a completely irrational way. Yeah. The the reality that after working really hard for 3 years and studying really hard for several weeks beforehand, the amount of stuff that I still felt like I didn't know. And again, the challenge with emergency and critical care is they could ask me questions about the heart. They could at a fairly deep level. And so what was painful about it was the practical reality that no matter how much you study and how much you train, there's still plenty of stuff that you don't know. And to like, I still get surprised. At this point, I've been doing this a long time, and I still have to sit back and go, I don't know. And then the resident or the intern will look at me and they'll be like, but you're supposed to know. And I'm like, dude, like you can't know everything. And medicine is so different. Like every patient is so different. Even if you think you got it, it can be a surprise. So, so yeah, it's just like the feeling of defeat in taking that exam, and ultimately I passed the test. So like I did okay, but it was still a very sobering experience. All right, I'm going to try to get through a couple of quick, interesting cases. And are we like, is 8 o'clock? Should I plan to try to be done right at 8? Yeah. Okay. And the case vignettes are pretty quick. I might be done by 8. But if I'm running a couple minutes over and you're interested to stay, hang tight, I certainly will not be offended if there's a mad rush for the door at 8 o'clock. All right. So we're going to start off with Jovi, who's a 1-year-old female spayed lab. who was found kind of roaming in the field, no tags, unknown owner. She seemed pretty bright and alert, had normal kind of vitals, and seemed very healthy, except for this, right? And just to give you, come on, out the way. Any thoughts on what's happening there? Yeah, so it's an arrow. And let me see, hopefully it will allow me to play it again. What do you think that arrow is doing? It's beating. So if you can see that arrow is beating. So this dog had been shot with an arrow. And that arrow, somewhat amazingly, went through what we call thoracic inlet and went straight through the heart. And is tickling, so that's the heart in the middle there. That's the diaphragm and the liver right behind it. So the arrow went straight through the heart. And in looking at this x-ray, what I could tell is there's not a drop of blood in this dog's chest, despite getting shot through the heart with an arrow. And so essentially what happened is thankfully the nature of this arrow is that the arrowhead was no wider than the shaft of the arrow itself. So the shaft of the arrow was sealing the holes that the arrow created in the heart. So no bleeding happened. So it's a really, really good thing that somebody didn't think, oh, look at this stick hanging out of the dog and pull the arrow. Never pull the arrow until medical care. Like it's one of the, and I'll show a couple of other quick examples, but this was extraordinary because there's also some other important structures in the chest. So it went straight through the heart, and the dog was standing there wagging its tail and looking at us. So it was unknown. We have this fund where we can help with stray pets that are brought in that need medical care. This was like a super cool case. We would have done it even if it wasn't cool, but so we take the dog to surgery, and essentially what happened is did a thoracotomy, so opened up the chest, and then placed what's called a purse string suture, which is an encircling suture around both holes. And then as the arrow was withdrawn, cinched the hole. The dog only lost 10 mils of blood in the entire process, which is just sort of extraordinary and really, really cool. And she basically was fine in 2 days, shot in the heart. And we never did identify who the owner was, so she was adopted by somebody at the veterinary medical center. And so she was named Jovi, after Bon Jovi, who had a song about getting shot in the heart. So that was a really cool case. Here's another quick arrow case. So this was a stray cat that also unfortunately was shot with an arrow. And it came in with the arrow kind of hanging out like this. And it's a little hard to see, but right here, this arrow did have feathers on it. And so the feathers were kind of stuck here, and that's why the arrow didn't go through and through. Now this looks pretty terrible, and I swear the cat is not deceased here. It's sedated and alive, but the arrow went through the side of the face, out the neck, back through the skin over its back, and out. The arrow went slightly through there's cartilage on the shoulder. There was a nice hole in the cartilage on the shoulder, and that was it as far as internal injuries. So another impressive near miss. This dog is a hunting dog and was doing its job, cried out, and ran to the owners with a small tree sticking out of it. Okay, so this is a fairly large stick that had penetrated into the dog's chest and abdomen. So this is a CT, and I'll show this view. So just to give you some perspective here, Oh no. Oh, so it's not loading the video, but essentially the stick came in about here, went through here, went in between the liver lobes, and ended right about here in the middle of the abdomen. So there was a lot of contamination. There was minimal blood loss. And again, we didn't pull out the stick until we were in surgery and knew what all was happening. And then that dog also recovered great and did well. Now, they don't all go like that, but these were some pretty cool examples. Another quick one I wanted to talk about, this was a little dachshund that was fairly lethargic, likes to chew on things, eat foreign objects, and essentially was found to be severely anemic with a hematocrit of 8%. And for perspective, your hematocrit should be 40%. So that's really quite low. And the serum looked kind of orange. Serum is supposed to be clear. So yellow and red make orange. And so we were concerned that there was some type of hemolysis or disruption of the red blood cells that was happening. And there's a list of different differentials that can cause that. So we got some x-rays and we found this. Anybody know what that is? What's it? Pill packet's a good thought. Any other thoughts? It's a Monopoly piece. It is the top hat from Monopoly. So this dog had eaten the top hat from Monopoly, which apparently for a few years, the Monopoly pieces were made predominantly of zinc. And zinc is a toxin that causes red blood cell destruction. So he got a little bit of blood. We did some endoscopy. There's the top hat hanging out in the stomach. Pretty cool. Got some fluids, IV meds, some other supportive medications. So we can see zinc in pennies minted after 1982. Bolts from carriers, galvanized crate bars, zinc oxide cream has a fair bit of zinc in it. It turns out also Monopoly game pieces. And it sits in the stomach, the zinc leaches out, and it causes damage to the red blood cells. So Boomer initially did well, but unfortunately, the amount of zinc that he absorbed ultimately led to other bad consequences, and that ultimately he wound up having to be euthanized. Not for lack of trying, but the take-home message is Monopoly kills. So not just kills time, but can kill patients. Okay, well, actually we're at 8:03, so I'll call it there. The last case was do you want me to keep going? Okay, I'll keep going. I got no, well, I do have things, but no. Okay, so our last case is Sky, and Sky is a 3-year-old female spayed pit bull who presented for stiffness and light sensitivity, and she had kind of gotten progressively more stiff and had sort of a glazed look in her eyes, and so she was referred to us for further evaluation. Hopefully this one will play. So does anybody notice like the forehead seems kind of pulled back and the ears seem kind of pulled back, and there's a bit of a furrow to her brow. And right now she kind of looks a little bit stiff as she's walking. And she also had a wound on her foot that looked necrotic. And so as we were trying to put some of these pieces together, anybody have any idea what might be wrong with this? Tetanus. Botulism would have been a great thought too. Botulism is more of like a flaccid paralysis. This is tetanus, absolutely. So, and here's kind of a profile view where you can see the ears kind of pulled back. She was not able to open or close her jaw. And so we made the determination this was likely tetanus. And so again, she had this necrotic wound on her foot. And essentially the toxins that are produced by the Clostridium organism enter the nervous system, migrate their way up the nerves, get to the spinal cord, and basically cause extra activation of muscle contraction. And so this is kind of the disturbing classic image that comes from human medicine of this kind of like contracted, curled appearance. And you can actually see that's where Skye progressed. Now, what we try to do is we remove the source of the clostridial infection. So we amputated the toe, we get them onto antibiotics, we put them onto lots of medications to relax them. The problem is once a nerve has seen the tetanus toxin, that nerve has to regrow in order to return function. And that can take quite a bit of time, up to 4 to 6 weeks to recover. And so she did develop a lot of complications. They have trouble eating, so we placed a feeding tube. She spent a total of 4 weeks in the hospital, and thankfully had very dedicated owners. You could see how contracted she was previously, and here you can see how stiff she is in her gait. And that tube hanging out the side is a gastrostomy tube that we could feed her because her jaw was so locked, she couldn't really eat on her own. But as she had kind of peaked in her signs, we started to give her a little bit more activity, trying to encourage her recovery. And after that 4 weeks, so in this picture, like we didn't take out her eyeball. She winked at me and we happened to catch it in the photo. And so she was one of my favorite patients. Like technically I was supposed to go off clinics and I was like, nope, not doing it. So Skybird and I hung out for 28 days, 29 days until she finally went home. Yeah.
When you have like a patient like this that's hospitalized for 4 weeks, is this something like if they had pet insurance that like they would work with them to cover something like this?
Yep. So pet insurance can be very helpful. Some insurance companies have caps on how much they're willing to cover. Skye did not have pet insurance, and the owners were very dedicated, and we hit 23,000 when all was said and done. They contributed 18, and we pulled together some resources from hospital funds to cover the rest. Because they were pretty committed, and we were close enough that it was like, we got to keep going, and we found the money. Can't always do that. Please don't be like, go to OSU, they got free money. But we do have some resources to provide support in select circumstances. All right, any other questions? All right. Oh, yep. So that case was, gosh, probably about 8 or 10 years ago. I followed her for 3 or 4 years after she was discharged. Last I heard, she was enjoying her nearly geriatric existence. And I didn't want to follow up anymore after that because I didn't want to know. Yeah. All right. Well, thanks for your time.
Coming, if you still have nurses pick up, Kayla has otherwise we will see you in a couple weeks. But lots of starting your